Hi, this is Caitlin Carter. I'm following up my prenatal bleeding and hypertensive videos. I did forget to mention on my vaginal bleeding one what would indicate a consultation or referral. Basically, anything that you think you're dealing with fetal demise, retained products, as in like a missed miscarriage, something along those lines. Any active bleeding / active hemorrhage, like persistent bleeding, lots of clots, basically soaking more than a pad in an hour. Also keeping in mind that those first trimester pregnancies are not going to be able to deal with as much blood loss before they're anemic and or shocky. So just being mindful of that. Any type of like frank bleeding in the second and third trimester. If there's pain of any kind, if we're worried that the pregnancy is anywhere outside of the uterus. Also shoulder pain, if that's part of it, they need to be seen immediately. If they are prior to 37 weeks, if they are having bleeding with uterine contractions, they need to go in. Infection, again, we can test for certain types of infections, but if they come back positive for any of those, we're going to need to refer them, at least in the state of Washington, to get a prescription for antibiotics if that's appropriate. And obviously, if we're listening to fetal heart tones or doing an NST or something like that, and if we're ever worried that we're having problems with that baby's distressed, obviously that's a referral as well. If this is something that happens multiple times, we're probably going to be referring. If we have any suspicions of any placental problems, previa abruption, vasoprevia, any of those type of things, we're going to work on those as well. That's all I can think of about that. So now I wanted to talk about hypertensive disorders. And again, it just said to talk about one of them specifically. So I was just going to talk about like preeclampsia, and if I thought that was going on, like what that would look like and how I would manage that. So preeclampsia is hypertension that happens after 20 weeks and hypertension is 140/90, greater than or equal to that, 2 readings over the course of 4 or more hours. So not just one reading, multiple readings. So it has to have that, and it has to have something else to go with it. Proteinuria, and that needs to be tested for. That's not just like pee stick in the bathroom type thing. A low platelet count, less than 100,000 platelets per milliliter. And I may consider running liver enzymes. I would definitely be running liver labs if I thought that was a problem. Pulmonary edema used to be one of those. As my preceptor says, she doesn't feel like we should be getting rid of that altogether. It's just not used for diagnosis, but can be like a clue in the right direction. Just like a urine dipstick is. Not diagnostic, but like, oh, hey, something's going on here type thing. It is considered early onset if it's less than 34 weeks or late onset if it's after 34 weeks. What that would look like is I would have noticed, for example, I may have noticed that as I was looking at a client's chart, like the numbers could have been like those creeping blood pressure numbers, or it could be like very dramatic, having like, oh, your blood pressure is very high today. Have her come back later that day, or go get her blood pressure taken someplace else, and see what that is, to determine if lab work needs to be done. Let's see. The client, you would be asking the questions about, have you had a headache? Do you have a headache that won't go away with, hydration, rest, Tylenol type thing? Just visual disturbances, dark spots, floaty, waviness, tunnel vision, those type of things. Do they have a history of any sort that we need to be worried about? Has this happened in a previous pregnancy? Do they have close family history? Does their sister have a history of hypertension or any type of hypertensive disorders? Is there anything that could not falsely, but anything, nutrition, hydration, substance abuse, those type of things that could be raising the blood pressure. So yes, that's still hypertension, but isn't like a hypertensive disease. I think that's how I want to say that. Let's see. That also may look like shortness of breath, nausea, vomiting, that right upper quadrant pain, things like that. Some of the things that we may be looking for in clinic, other than the actual test of testing blood pressure, is reflexes, again, edema, proteinuria, those things. So we've decided she has high blood pressure. I'm going to have her pee on a stick. We're going to see what that looks like. We're going to do some blood work. We're going to order a CBC and liver panel if I feel like that's appropriate. Probably a urinalysis wouldn't be all that bad of an idea as well. And again, we're going to evaluate the fetus and make sure that that baby's looking really good as well. Our treatment plan is really going to be determined by how far along she is, and history, those sort of things and that, if this starts happening or if she has a history, we can do low-dose aspirin in that 12 to 16 week range. And we can also be doing like some more of the complementary type things. We can do calcium, we can do hawthorn, we can do garlic, cramp bark. Also, any of the liver support is always really good as well. Dandelion, nettle's really good. It has the calcium as well. Any of those things to support the liver are going to be really beneficial as well. Stress management is always a good thing. I think it's a good thing for everybody, but anyway. I've also heard, I wanted to mention the recipe that was mentioned in the live session that I wrote down, that I really liked that. That was the lemon or lime juice and the cream of tartar with water. I don't feel like that's going to hurt anything, and I would be happy to try that. Let's see, when am I going to refer? I'm going to be watching things really closely. I've kind of heard a couple of very scary stories from midwives that I highly respect, in that hypertensive disorders can be creeping, or they can be very sudden and very severe. So I'm definitely going to be watching things closely and just consulting if I need. Like, we have a really great doctor here. It's no big deal to call him and just have a conversation, go have an appointment with them, just to kind of see if it's, I guess depending on whenever it is, it's never a bad idea to have increased fetal surveillance. But we also need to be really aware of when hospitalization is necessary, and make that referral as needed. So the indications that really something needs to happen very quickly, as far as baby needs to be born, is that really severe headache, abdominal pain. We know we may have gotten labs back and our liver panels are bad. The serum creatinine is rising. Those platelets, the thrombocytopenia, platelets can be dropping, that pulmonary edema, non-reassuring NSTs, or abnormal biophysical profile. Yeah, I think that's everything. I'm sorry, I'm trying to keep these videos short, like cramming all of the information in as well. So thank you, and I apologize for being long.